everyone for being here to attend this most exciting event that's about to unfold. We are likely now to actually going to the last leg of our Cardio-Renal-Metabolic Congress. I understand this is a very year-long saga that has already been introduced in Vietnam, subsequently Korea, now in the Philippines. We are now about to embark on hearing all the experts talk about what is most important in our hearts. Cardio-renal metabolic diseases are caused by overlapping pathophysiologic processes that are interconnected and amplify each other, necessitating a multitasking, multi-team approach for which all healthcare professionals are tasked to reduce debilitating conditions that could arise from them. This profound relationship should be averted early so that we don't actually face them when end of life is already at hand. Our mission today is to overcome the barriers, help shape the future of managing cardio-renal metabolic diseases through the collaborative efforts of everyone who's listening in. I understand we have being attended not only by those who are in front of me, but virtually we are also attended by healthcare professionals across Southeast Asia who are battling the same battles, hurdling the same hurdles, and eventually attaining the same success. To navigate the intricacies of these interrelated conditions, we have distinguished speakers who will share effective strategies and guidelines for hypertension management and diabetes management. By embracing evidence-based practices and cultivating synergy in the management of our cardio-renal metabolic diseases, we can enhance the management of all, eventually making a landmark in changing the outcomes of this patient. How are we going to do about it tonight? The scientific agenda for tonight has actually been modified to make it quite interesting. First and foremost, nothing grounds us more than starting with a case study. It's very difficult to talk about hypothetical cases, so let's start from reality, which will be presented by Dr. Maria Rosan Trani, our very own in the Philippines. Subsequently, we want a tete between our endocrinologists and our nephrologists regarding what do they think about the case and how do they think things or actually concepts can be introduced to change the course of their illness. We'll talk about diabetes and hypertension risk mitigation strategies, followed by harmonized practice guidelines and adherence. Subsequently, let's see. Dr. Atrani will come back and actually talk about how the case will be. Our distinguished speakers from the endocrinologist point of view will be Professor Stephen Jacob. Subsequently, from the nephrologist point of view, will be Professor Bobby CHACKO. Subsequently, let's open the floor. It's your time then to discuss with us. When you have poll questions in the interactive session, we want to hear your voice across everyone who's hearing this particular Congress. And then later on, please, Slido is open. Feel free to field questions to us. This is the time to discuss. This is the time to query. This is the time to answer. Before we actually finally summarize and close the event, hopefully timely and productive. Without further ado, let us start the ball rolling as we start the night. Let's all enjoy.
Thank you, Dr. Helen Ong Garcia. Our discussions will start with a case study presentation by Dr. Maria Rosan Trani. At the KHOA Hospital in Cebu City, Dr. Trani is the chairman of the section of cardiology and adult cardiology training program. She leads the research fellowship training program in cardiac rehabilitation and heads the cardiac rehabilitation units at Perpetual Socorro Hospital and KHOA Hospital. Dr. Trani is a past council chair of the PHA Council of Cardiac Rehabilitation and Sports Cardiology. She is a fellow of the Philippine College of Physicians, the Philippine College of Cardiology, and the American College of Cardiology. Please welcome Dr. Maria Rosan Trani.
Good evening. Welcome to tonight's symposium. It is my privilege to go over a case that we usually see in the office. These are my disclosures. And so let's go right onto the case. So this is actually a case of a 38-year-old woman who works at a call center actually for the past 9 years, taking the the evening shift. She's a non-smoker, takes alcohol occasionally, consumes about 2 to 3 cups per day, apparently had a diagnosis of PCOS, and a family history of hypertension and diabetes. However, no family history of an actual cardiovascular event. Initially, the patient sought consult a year ago from their company physician for headache and nape pain. The blood pressure was apparently elevated and was noted to be at the level of 140 to 150 over 90 and a diastolic of 90 to 100 millimeters mercury. She was then given telmisartan 40 milligrams once daily, however, failed to take the medication regularly. Workup then showed the following. The fasting sugar was elevated at 140 and a glycosylated hemoglobin of 8. There was glucosuria, and the lipid profile did show some metabolic abnormalities. An elevated cholesterol, total cholesterol level, and an LDL for a patient with diabetes is on the high side. A statin and metformin, a statin was added and metformin was up titrated to 1.5 grams a day. However, as most of these young individuals usually work in a call center, they are usually lost to follow up, until about 2 weeks when she came over, because this time she was having dizziness. When she goes up the stairs, there's already some exertional dyspnea, and palpitation was quite prominent. The blood pressure taken then was 150 over 100, and a heart rate of 80, and on the overweight side. Although her physical examination was unremarkable, the latest workup showed still with the elevation of your sugar levels, with an HbA1c that is still at 7.6. There was still proteinuria, and the kidney function, though, remained acceptable with an eGFR of about 121. The electrolytes were also okay, and the thyroid function tests were likewise normal. And so just before we turn over our discussion to our 2 invited foreign speakers, let me just go forward about talking about hypertension. Cardiovascular disease, as you know, is a continuum. And this trial, this big large meta-analysis given to us by the Blood Pressure Lowering Treatment Trial Collaboration Group, emphasizes that it is about controlling the risk factors before we go into the symptomatic and even to mortality. And this is for every 5 millimeter reduction in blood pressure, this lowers the risk of about 10% on the average. So as physicians, we should really emphasize that we get to goal in trying to control the risk factors and not just the blood pressure levels. Here we see in this slide that early and effective management of the blood pressure prevents the deterioration. This is key, it is a key measure in the reduction of cardiovascular risk, such that it is always a cornerstone in our preventive strategies. And among patients, particularly in this subset with grade 1 hypertension, again, the trials tell us a significant impact on the reduction of different cardiovascular events by treating. And this may be the possible causes, that they may still be on monotherapy, and that they may not be aligned to the following the international guidelines of promoting at least 2 drugs to really get to goal, and of course not really optimizing the dosages of the different medicines, and of course compliance problems. And so with that, I'd like to end this first part while we discuss the other metabolic and renal problems of a patient. Thank you.
Thank you very much, Dr. Maria Rosan Trani. A multidisciplinary approach is considered effective in helping overcome the complexities of patients with diabetes and comorbidities, such as hypertension. So from a case study presented by our esteemed cardiologist, we will now take a look at diabetes and hypertension risk mitigation strategies from the perspectives of an endocrinologist and a nephrologist. Professor Stefan Jacob is an endocrinologist, diabetologist, nutrition expert, and clinical hypertension specialist in private practice. He has established a Cardio-Metabolic Institute to coordinate the outpatient care of cardiometabolic patients, including non-pharmacological and pharmacological therapy, as well as lifestyle coaching. His aim is to establish a network between family doctors and clinics in his town. Furthermore, he is a SCOPE founding fellow as well as a member of the IASO Collaborating Center for Obesity Management. Professor Jacob teaches at the University of Tübingen in Germany and is involved in several clinical trials in obesity, lipid, and blood pressure management, specifically the CV outcome trials of new anti-diabetics. He is a member of several guideline committees and editorial boards and is in the board of both the Working Group on Diabetes and the Heart of the German Diabetes Association. He is likewise head of the Research Group on Cardio-Metabolic Care at the University of Munich in Germany. Professor Jacob will speak from an endocrinologist's point of view, while Professor Bobby CHACKO will share his perspectives as a nephrologist. Professor CHACKO is a Director of Renal Services at the Department of Nephrology and Transplantation of John Hunter Hospital in Newcastle, where he is likewise a Senior Staff Specialist in Nephrology. He holds a conjoint appointment at University of Newcastle and is passionate about medical education and clinical research. Dr. CHACKO also serves as a chair for the NSW/ACT Renal Advanced Training Recruitment Committee. He's the national leader for 3 clinical trials in IgA nephropathy and diabetic kidney disease and has published over 60 papers in peer-reviewed journals. Let's delve into diabetes and hypertension risk mitigation strategies from the standpoint of endocrinology with Professor Stefan Jacob.
Thank you very much. It's a great pleasure to be here and a great honor. And I want to thank the organizers for inviting me. They must have known that for years I have been working in a working group diabetes and hypertension, looking at the interaction. And at that time, many others also discovered that people with essential hypertension, even if they are non-diabetic, they are very insulin resistant. And this is why I would say, when we now start looking at our case, it was not a big surprise to find out that she is not only hypertensive, but she also has full-blown diabetes. We know that there's a strict association. She has some family traits. She has a family history of diabetes. And I tell you what, people with hypertension are very prone to have full-blown diabetes or pre-diabetes early on. This is an old, but to me, a very fascinating study from Germany. They were, in the 90s, looking for patients with hypertension and no diabetes to be included in a study. And the doctors sent their patients thinking that they all had no diabetes. In order to confirm that, they had to perform an OGTT at the clinic. And guess what? A quarter of them had full-blown diabetes. 41% had impaired glucose tolerance. And only 30% were having a normal glucose tolerance. That's something. You know, this is a pre-selected group, and they had thought that they were non-diabetic. And I'll tell you one. If you were to look at the NGTs, and if you would measure the insulin levels during the OGTT, you would find out that 2/3 of them have profound hyperinsulinemia, indicative of insulin resistance. So this is no big surprise, but it's not yet very well known that diabetes type 2 and hypertension go along, not only connected through obesity. If obesity is on board, of course, this drives the whole story much more. In the year 2002, we got a very interesting study, because at that time, you might remember the impaired fasting hyperglycemia as an entity to easily detect people with impaired glucose metabolism was introduced. And this French group was looking at more than 60,000 patients. And they looked at impaired fasting glucose defined as such. And they did find that in these people with hypertension, that 17% already showed increase in fasting glucose. And then they observed the whole group for 8 years, and they looked at cardiovascular mortality. The first thing which was noted here is, you see the different age groups, and you see the incidence of IFG, impaired fasting glycemia, and you see, according to the blood pressure groups, the higher the blood pressure was, the higher also the prevalence of impaired fasting. So this is one thing. But the next thing is, I would say, shocking. When you look at the rates of mortality in people with normal glucose below 110 and compare it to those with just having slightly higher fasting glucose, look at that. It's almost more than doubled, it's almost tripled. So this really plays an important role in exaggerating the cardiovascular risk. If we move on further, you have seen the lipids. If we look at the pattern of the metabolic syndrome, having our patient, she is overweight or obese. And if you look at the combination of the metabolic syndrome and you look at echo, the prevalence of albuminuria or retinopathy, you see that those people being hypertensive but having the cluster of the metabolic syndrome, in comparison to those without the metabolic syndrome, have a much higher prevalence of these end organ damages like albuminuria, retinopathy, and left ventricular hypertrophy. So again, it's not only glucose, we have to move on and look at the whole picture. And when we look at the event-free survival, as it was done in this Italian group, you see that compared to those without the metabolic syndrome, those with a metabolic syndrome had a much worse outcome. Therefore, then going through all these different pathomechanisms down to development of micro and macrovascular disease. So not only this is relevant, you recall that in the metabolic syndrome you have the HDL playing a major role and you have the triglycerides playing an important role. If you just look at high cholesterol, you would also acknowledge that in addition to the increase in events with increased systolic blood pressure, people with hypertension and concomitant elevation of cholesterol have a much higher rate of events, and if you put this together, you see it's almost doubled. What do I mean to say? When we have someone with hypertension, you cannot be quiet and wait for the next appointment and see how blood pressure has been managed. You need to stage the patient, because hypertension is a silent killer, but dyslipidemia and diabetes as well. And if they come together, the risk goes up. So that's why I keep telling the German doctors that we have to do some staging. We are used to staging people with cancer, but we are not staging in people with cardiovascular risk. So what could we do? Well, I think one of the most important connectors is the overweight. If we were to reduce the body weight, we would get a full hit. We could kill several birds with one stone. And I think we should use that first. The lady was first diagnosed to be diabetic. It's important to get education and to explain to the patient the association and why she needs to work on her body weight and improve her food intake and all that. One of the diets which turned out to be quite easy, it's the DASH diet. Dietary approaches to stop hypertension. It was a study done to lower blood pressure. And some of you might know this study. They really did achieve a much better blood pressure control, in particular as they increased the fiber intake. And they had less saturated fat. And guess what? This diet also had a much better lipid profile later on. And this diet also later on had a lower rate of diabetes. And I think this is quite easy to explain to the people. Eat more vegetables and more fiber-rich diet. And keep off the isolated sugar. And on the other hand, a very easy thing is just walk, don't run, don't exercise and force yourself. This is a very interesting study, a small study from Italy, where they had people at the age of 62 being trained for the Nordic walking with the sticks, and they followed them for 2 years. And after 2 years, they looked at those who did walk, I forgot to translate that, 0 hours a week, the couch potatoes, or those who did much, much more. And here you see all the different risk factors like body weight, waist circumference, and all the other things. Now you see everything turns green, which becomes significant. And I think it's amazing to see that just walking about 45 minutes a day had these terrific improvements of everything. Imagine if we had a drug, you take a drug, and it hits everything. Diabetes, dyslipidemia, blood pressure, and so on. I think every one of us would buy the drug. The same group also did show that when you divide that and have 3 short walks, you get a similar benefit. I think it's easy for the people to do this. You don't have to run. On the other hand, just a word of caution as well. This is a study, the Look Ahead trial, which you might remember, which was a lifestyle intervention trial in the States. The participants were undergoing intensive lifestyle modification, including intensive exercise, and the GPs who send the people there should kind of sign that they are ready for exercise. However, when they did proper tests, it turned out that almost a quarter of them had exercise-induced abnormalities. So please don't put your people out there and say, you have to do some more exercise. First check, because some of them, due to uncontrolled blood pressure and all that, might run into major problems. Let's now turn to the blood pressure and diabetes. Evidence-based medicine clearly shows that it is very, very important to control blood pressure. You see, all these morbidities are being reduced. So there's no way, Jose, that we are not treating blood pressure, and we should treat blood pressure accordingly. But we have to break down the walls, because we are not only treating the blood pressure, we have to consider the whole risk. If we just lower blood pressure, we might not reduce the cardiovascular risk. And sometimes we were using the wrong drugs. And this is a recent meta-analysis which was looking at blood pressure lowering and the risk of new onset of diabetes. And it turned out that if you look at all the trials which were available, it's the angiotensin II receptor blockers and the ACE inhibitors being associated with a significant lower risk of diabetes. Whereas people treated with beta blockers had a 50% higher risk, and those with thiazides had a 20% higher risk, while calcium channel blockers were neutral. So I think it does matter what we prescribe to these patients, and it is of great importance to remember that. Also, when we now look at her, she had an HbA1c of 7.6 after she had been treated with metformin. Hey, she's far away from having a good glycemic control. So this is why we have to find something which makes it easy for the patient, because she came to the doctor with some pain and ended up with a lot of medication. So we need to have a drug which is fitting her, which is easy for her, simple to use, which doesn't carry any risk for hypoglycemia, because she should exercise, she should diet, so there should not be an interaction. And this drug, linagliptin, has been tested in so many conditions. You know this, that you can have one drug for all these conditions. And the very good thing is that we know that when you give the drug and you exercise, you are not having the risk for hypoglycemia. While we learned in the Carolina trial that people treated with SU, not only in the phase when you initiate the treatment, but over the course of time, tend to have a very high risk for hypoglycemia, and this is documented hypoglycemia. There's another point I want to make, and that was discovered in that trial. When you compare people with glimepiride and linagliptin, you find out that independent of the age group, you get a higher rate of falls and bone fractures. Oof! How can you explain that? Glimepiride causing changes in bone metabolism or something? No. Most probably, as the authors discuss, they're causing mild hypoglycemia, and that is associated with stumbling and falling. And I think this is something we have to also consider. And I do think that this is of major importance, in particular for the elderly population, for postmenopausal women, and so on. And last but not least, we have to treat and see this patient for a long period of time. At the beginning, there are few comorbidities, but over the course of time, you will have more and more comorbidities because the people age. They will have more complex treatment regimens. So how are we dealing with safety in that condition? And this is why it's great to have 2 dedicated cardiovascular outcome trials for linagliptin, which is the Carolina trial in people with early diabetes. These were people without insulin, a little bit of cardiovascular comorbidities. Whereas at the later stage, you have people in the Carmelina trial with 15 years of diabetes, a very high risk population with a lot of kidney problems, cardiovascular problems, and the combination of both, and complex treatment regimens. In these 2 populations, we have proven safety for these people, not only cardiac safety, also in this high-risk renal patient group, you have renal safety and even an improvement in microalbuminuria in people treated with linagliptin. And when you guys put this together with the other available DPP-4 inhibitors, it is important you know from an evidence-based perspective that these are the only drugs which have a dedicated cardiovascular outcome trial, most of them in secondary prevention. Some of them had primary prevention included, but they had a problem with a heart failure hospitalization. And when you go on and you look at the others which are available in your country, you see that these don't even have any single cardiovascular outcome trial, so they don't have any available evidence that they are safe in this population. And the best evidence for people in primary and secondary prevention, and also in people with heart failure, you see for linagliptin in Carolina and in Carmelina. With this, I want to end, and I hand over to the expert for peeing.
Thank you, Professor Stefan Jacob. We shift our focus to risk mitigation strategies in diabetes and hypertension from the perspective of nephrology. Please welcome Professor Bobby CHACKO.
All right, good evening and thank you for having me. Thank you, BI, for inviting me, and it's great to be back in Manila. A word of advice, never have a nutrition specialist sitting with you in a dinner table. You'll end up eating only salads. At least we tried to. So, my session is on the diabetes and hypertension risk mitigation strategies, but looking at it from a nephrologist's perspective. So I'm going to take this case very differently and go through this with you. So what are the issues that I have identified in this lady? She's 38 years of age, that is young. She's a female, and there's a reason why I bring that up. She's got a BMI of 29. A BMI of 29 in an Asian population is not overweight, is actually obese. All right, so let's be very clear about that. This patient has got hypertension at age 38, has got diabetes at age 38, and a GFR at 121 mils per minute, which you will all think, oh, that's fantastic. And a urine ACR at 29 milligram per gram. So you'll say, okay, right. Let's look at the definition of CKD. The KDIGO definition of CKD is that if you have a urine abnormalities or structural abnormalities or a GFR of less than 60 for more than 3 months, that's CKD. You're all familiar with the CKD heat map, and according to the CKD heat map, our patient will have a urine ACR at 29 milligram per gram and has got a GFR of more than 90. In the green zone, happy days, you can all go home. Well, that's what you think. I think a little differently. If you think the GFR of 123 is good, I would look at it very differently. I'm looking at it, and I'm looking at the CKD Prognosis Consortium paper that was published last year. And this is going to shock you. What you think is a normal GFR, to me, is actually a supranormal GFR. There is a problem here. Now, look at these white spots here. These are the reference group. And look at the GFR that you're looking at, 90 to 104. Now, when you compare that GFR to Our Lady's GFR, which is high, and you look at the urine ACR between the 10 to 29, you are seeing a 2 times higher risk for mortality, for myocardial infarction, for cardiovascular mortality, for stroke, for kidney failure, for heart failure. Now suddenly, from being normal, things are looking very different. And why that is important is that when you see a patient who's got this high GFR, it is a sign of hyperfiltration. And the only 2 things that can fix that hyperfiltration in this patient is absolutely controlling the blood pressure with the best possible agents and controlling diabetes. Intensive glycemic control at the start of diabetes is going to counter that hyperfiltration process. Okay? Totally different from what you thought this patient is going to have. Now, what could have been done for this patient to diagnose hypertension or screen CKD at an earlier stage? So we're going to talk about screening, who should be screened, and how would you screen? Now, we're all familiar with the ISN toolkit, so you determine people who are at risk for CKD. It's very simple in this patient. This patient has got diabetes and hypertension, no brainer. You have to screen for CKD. And how will you screen for CKD? Very simple. You have 2 tests to do that. You have a urine test for the urine albumin-creatinine ratio, and you do a blood test to calculate the GFR, which we have done in this patient. The ISN acknowledges that not every country will have a urine ACR at their disposal. So they acknowledge that fact, and they say that a urine dipstick is good enough to identify albuminuria or proteinuria in this group of patients. Now, because a patient has diabetes, you should screen for diabetic kidney disease. So in which patients will you screen? Initial screening should commence 5 years from the onset of type 1 diabetes. But in this patient, we have a type 2 diabetes, so screen from the diagnosis of type 2 diabetes. And we've already spoken as to how you screen for kidney disease. But what about hypertension? Who are you going to screen for hypertension? You have systematic screening versus opportunistic screening. Systematic screening is that you are actually asking your patients to come into the clinic for the diagnosis of hypertension. It simply does not happen. What we have to rely on is opportunistic screening. And this case exemplifies this. This lady came into a doctor for headache and neck pain, and you had a blood pressure checked, and things changed. So that is what we should all do, that never miss an opportunity to diagnose hypertension. Anybody come into the clinic for anything, that is an opportunity for you to diagnose, because this is a dangerous condition, as you will see. So you screen for hypertension, and if the patient is less than 40 years of age, you're expected to screen typically every 3 years going forward. But if it's more than 40 and if you have risk factors, then you need to screen more frequently for hypertension. Now at the beginning, I did point out that when I looked at this case and I said, great, there's so much points to discuss, because the one thing that I as a nephrologist ask every patient who sits in front of me and who's a female is, what is their obstetric history? Because that tells me what the future cardiovascular risk in that patient is going to be. And that is very relevant here. I would be surprised, and I don't know the case, I would be surprised if this patient did not have preeclampsia. I would be surprised if this patient did not have gestational hypertension. I would be surprised if this patient did not have gestational diabetes. We had an opportunity very, very significant going forward. Now, I also mentioned the fact that she's a young lady. She's 38 years of age, has got hypertension. And doctor has already mentioned she has a family history of hypertension. So the first question you're going to ask is, At what age in the family did the patient's parents got hypertension? If it's a young hypertension, then you might think that there might be a familial story here that it could be primary hypertension, because our definition of primary hypertension, the age group, is getting younger and younger every day now. But for the purpose of discussion, we have to assume that this lady may have secondary hypertension. And I was particularly interested, the second set of slides, the potassium was 3.9. And that is a little slightly low potassium. So if you have spontaneous hypokalemia, you will have to think for renal vascular disease as a cause of hypertension. Now, if you look at the age group distribution of hypertension, you would find that the 19 to 40 years, you're looking at monogenic disorders, and you're also looking at fibromuscular dysplasia for the diagnosis of hypertension. So don't assume that anybody who comes to you has got primary hypertension. Secondary hypertension must definitely be thought about, particularly in this lady who's got very high blood pressure and did not improve. Now, putting it all together, because our lady has got both diabetes and hypertension. And this is a great slide that brings together everything together, isn't it? So we know that both diabetes and hypertension are the same shared risk factors that leads to kidney disease and heart failure and cardiovascular disease as well. So we have to start moving away from the one patient, one condition. It's never going to be like that anymore. And I have a way of dealing with my patients, and I say, in my world, CKD stands for chronic kidney disease, but in my world, CKD also stands for cardio-kidney diabetes. So everybody who's got a cardiac problem should be thought about a kidney problem and should be thought about diabetes, because they are likely to occur together than occurring in isolation. So keep that in mind when you see your patient with either problems in there. And this multi-morbidity paradigm puts together things even better. So your patient had hypertension, her ECG did not show left ventricular hypertrophy, this had progressed to heart failure, and on the other side, you have albuminuria, decreased GFR, and kidney failure. They always converge. The kidney and the heart are always talking to each other and converge. Now, this lady has got diabetes, and it's important to recognize that 1 in 3 people with type 2 diabetes will have cardiovascular disease. 15% of the patients with type 2 diabetes will have heart failure, and up to 40 to 50% of the patients with diabetes can develop kidney disease. And in fact, CKD and heart failure are the most frequent first complications in a patient with diabetes. And it's very important that we think about these conditions going forward. So why is managing hypertension important? Because you have all the end organ damage here, the hypertension-mediated organ damage for the eye, the heart, the kidney, microcirculation, large and medium arteries, and brain. But nothing compares to what it does, is hypertension is a silent killer. It kills people. 2015, nearly 10.7 million deaths were attributed to hypertension, with a blood pressure not necessarily in the 140 range, even at 110, 115 blood pressure systole, you can contribute to death. So my brief on this session was diabetes and hypertension risk mitigation strategies. And I looked at it and said, that's interesting, because in my view, this patient already has diabetes, already has hypertension. In my view, the ship has already sailed. So what risk mitigation strategies are we going to talk about? We have to focus now on CKD management, cardiovascular disease management, and the hypertension-mediated organ damage. That's where the key comes to. So the next 2 slides, which I finish, the only proven primary prevention intervention for CKD in people with diabetes, hear me out, are glycemic control, intense glycemic control at the start of diabetes. With all the new medications that we're coming across now, people say diabetes is not about managing glucose. And I beg to disagree. Yes, later down the line, when the horse is bolted, maybe the glycemic control is not so important. But at the start of diabetes, we should get away with the inertia because intensive glycemic control is still the best way to go about. And the second is the blood pressure control. So as soon as you have hypertension, you need to bring down the blood pressure very quickly because there is no evidence as of yet that RAS blockers or any other interventions prevents the development of diabetic kidney disease in the absence of hypertension or albuminuria. Now, last year in the EASAD, the 44 years legacy data for the UK PGS was presented. And it is stunning to see even 44 years after the UK PGS, the group that had the intensive glycemic control still had the best outcomes. But the key word and the phrase is intensive control at the start of diabetes. As soon as possible, we would like to get the HbA1c below 6%, so you don't waste time. Cardiovascular risk assessment. Now, I'm not sure what parameters you use in the Philippines. We have been using the Framingham score. We have been using the score in Europe. But that's all for the Western population. The Asian population, we don't have necessarily a scoring system that actually calibrates to the Asian population. And our Asian population is very different from the Western population. Okay, we got the highest burden of hypertension. More than half of the world's cardiovascular disease events actually happens in Asia. Diabetes, of course, we are the world's capital. We have a lower level of patients who are having HDL levels of cholesterol. And the ratio between stroke and coronary artery disease is different in Asia compared to those in the Western countries. It's more stroke here than coronary artery disease. So we can't be using the Framingham risk score because that's very different to the Asian population. And we do not have a risk stratification score for the Asian population, unfortunately. So for the HMOD or the hypertension-mediated organ damage, I'll leave you with this slide, the ESH master plan for the hypertension management. So stay tuned for my next section when we talk about this. Thank you.
Thank you, Professor Bobby CHACKO. After discussing risk mitigation strategies, we now direct our attention to harmonized practice guidelines and adherence in type 2 diabetes and hypertension management. Once again, here is Professor Stefan Jacob with endocrinologist's perspective.
Well, thank you very much. To get an insight from the nephrology perspective, I just want to add on. There's one very important issue which I have, although I'm a diabetologist. I'm not a sugarologist, but I want to say that as she was diagnosed to be diabetic newly, and as she was already hypertensive, we really have to instruct her about her silent killers. And we do know that if we tell them, oh, you've got diabetes, oh, you have to do some kind of a diet as we did in previous years, she doesn't understand the seriousness of the disease. And that is why it is very, very important to inform the patient that she is at very high risk and that on the other hand, that we need to do whatever we can, and we can, to protect the vessels, the heart, and the kidney. Because my patients, when I tell them, listen, your glucose is not well controlled, your lipids are not well controlled, your blood pressure is too high, they smile at me and they say, doctor, that doesn't hurt. Why should I change? And I think this is very important, that we explain it to the patient. Don't forget, 99.9% of the rest of the time, the patients are left alone. They only see us every once in a while. And it is on us to explain to them the situation. So I want to move on, and we really need to reassess what we are doing, and I want to share with you some thoughts which go beyond the conventional diabetes management, as I named it, the sugarology. Because for years and years in type 2 diabetes, we were just looking at lowering HbA1c, and we thought the lower the better. And then, after we did see the Accord trial that more people died in an intensive treated arm, we said, oh, we want to have a good HbA1c control, but without the sequelae of hypoglycemia and weight gain. So this is written in the guidelines. But I think it took a bit of time for us to understand that our target of treatment is not a lab value. It is to reduce cardiorenal events. And if we really want to reduce cardiorenal events, it's not enough, in particular with her, to fool around a bit with blood pressure, to fool around a little bit with glucose. No, we have to do everything at once. We have to do the strict blood pressure control, we have to do the strict lipid control, and also we have to do the strict glucose control, best with agents with proven safety. So indeed, in the field of diabetes, we are moving away from the pure glucose centricity to the end organ protection. That means we have to be vigilant and detect also the other factors, such as the hypertension, which is uncontrolled. And EASD and ADA issued some new consensus reports in which they say if we want to prevent complication in type 2 diabetes, it is about glycemic management. Yes, it's important. But at the same level of evidence, it is also weight management, because it's so important. At the same level of evidence is risk factor management, as we just discussed. And at the same level, it's cardiorenal protection using safe drugs and, as I said, all with the same importance. Now we are going into a problem. If we really want to tackle everything and have a good blood pressure control and a good glycemic control, that's a lot of tablets if you really want to achieve goals. And just keep in mind that in order to achieve adequate blood pressure control, most of the people with diabetes need 2 or sometimes even 3 different components. And on the other hand, the more complex the dosing is, the less the adherence. Or take it the other way around, if you have once daily dosing, the adherence will be much better. And furthermore, if we can put these tablets in a fixed dose combination, it's going to be much easier for the patient, because we do see in many trials that the compliance is much better and the achievement of good control is much higher. Even in the secondary prevention, just talking about that, it's the SECURE trial, which was published 2 years ago at the European Society of Cardiology. In people who survive the myocardial infarction and do know how important it is that I do get everything controlled, the free combination of taking all the tablets versus the poly pill was much less efficacious than the poly pill. So I do think that we always have to keep in mind the burden of the different drugs regimens for our patients. On the other hand, we really can achieve a lot in people with diabetes. And I like this article because it comes from the Swedish Diabetes Registry. What did they do? They observed more than 13,000 people who were diabetic and hypertensive, and they were followed up by 6.5 years. So the important issue here was that they checked whether HbA1c was indeed lower by minus 0.5 absolute percent, whether systolic blood pressure was reduced by definition by minus 12 millimeters mercury, and whether LDL was also reduced. The very, very sad news is there were 50% who didn't even achieve one of the targets. There were 14% who achieved at least an HbA1c drop in these years. There were 15% achieving an HbA1c drop and a blood pressure drop. And altogether, there were only 21% of the whole population achieving the three targets. We are not talking about normalization. We are just talking about an absolute drop of these values. So we are not doing very well out there in the field. And when you now look at the survival, and you have in red those people who didn't have anything controlled, compared to those who had at least HbA1c or HbA1c and blood pressure controlled, or the green ones achieving everything, you see that fatal coronary heart disease, cardiovascular disease, or cardiovascular disease or total mortality, they were very high and they were dose-dependently reduced, having the lowest rate in those who achieved the control of all these three factors. And again, it was not normalizing the blood pressure, it was not normalizing the glycemic control. So there is a considerable improvement of outcome when you really manage all three. And this is now getting a bit more complicated because we are all treating the same patients, but we always have been used to take different perspectives. We looked at the glucose. That was okay. We looked at the blood pressure. We said, it could be better, but that's okay. We looked at the lipids. We said, you got to watch it. But when you take this all together, you realize, wow, the risk goes up like crazy. And if you have a little pathology from all these threes, the risk goes up. But if you manage to control all that, the risk can be modified in a drastic way. And this is why more and more we are talking about the cardiovascular renal management. And we recently created a cardiometabolic renal working group, which calls upon all of us to break down the silos and to see the patient holistically and to really see and check all the evidence of different risk factors, to maybe also involve someone like him, a nephrologist, also a cardiologist, in checking these patients, in helping us to improve and to, first of all, find out the best guideline-directed medical therapy in order to improve the outcome. In the States, they do have cardiometabolic centers already, and the first results are very encouraging because they did find after 1 year 3 times better risk management than in the conventional groups, and within 1 year almost already significant a reduction in the hospitalization for complication. And that means a lot of money and sorrow saved. With this, I hand over to the nephrologist, Bobby.
Thank you, Professor Stefan Jacob. We are pleased to welcome back Professor Bobby CHACKO, who will share the nephrologist's insights on harmonized practice guidelines and adherence.
Okay, thank you. I'm back. So, get the first slide. So, when I left the stage for the ESH master plan for the management of hypertension, and I put this slide up here to put it all together because hypertension is not a single issue. There are a lot of factors that comes into play. And as you can see here, it can be genetic factors, various mechanisms in the pathophysiology of hypertension makes sense. There is the blood pressure regulation that's from the RAS and whatnot. There's environmental factors, noise pollution, traffic in Manila, maybe, yeah? There's all risk factors for hypertension. Now, what I'm going to take you through the next 10 minutes is the guidelines for hypertension. These are the 2023 guidelines that I'm talking about, and I've taken this from the 2024 European Society of Hypertension Clinical Practice Guidelines for the Management of Hypertension. So stay tuned. As I said, this is coming from the 2023 guidelines. The master plan is very simple. It stands for the acronym MASTER. M stands for measuring blood pressure, that is to diagnose hypertension. A for assessing the patient, S for selecting treatment, and ER is for evaluating response. So let's take each of them. Measuring blood pressure, the diagnosis of hypertension is dependent on where you actually make the diagnosis of hypertension. Clinic recordings are one that we often do. So 140/90 is the blood pressure, at which point above you will make the diagnosis of hypertension. But if you are using a 24-hour ambulatory blood pressure recording, a value of 130/80 is sufficient to call hypertension. And if you're using a home recording to monitor blood pressure, a target of 135/85 is enough to diagnose hypertension. So 140/90, 130/80, and at home 135/85. You need to assess your patient. So the basic of assessment, and the doctor has already mentioned about, you do the history, physical examination, laboratory tests. Now simple tests like the urine ACR and the GFR, the lipids, which have already been mentioned, and then you extend that to looking for hypertension-mediated organ damage by ECG, sometimes the coronary calcium score. I'll be very interested in a coronary calcium score in this lady. I'll be surprised if she had a low score. And some Doppler assessment, especially for looking for secondary causes of hypertension. And when you're in doubt, refer to a specialist. The S stands for selecting treatment. Now that, before we go on to the medical management, we should be looking at the non-pharmacological management. And Stefan has already mentioned about this, but I think it's not to be understated the importance of lifestyle management for hypertension. Exercise, quitting smoking, a diet rich in fruits and vegetables, and cutting back on your smoking. I already mentioned alcohol, exercise, everything helps. But after you've done all this, then you look into, did I go backwards or forwards? Management. So when you select an antihypertensive treatment in this day and age, you have the ABCD of blood pressure control that you start for every patient. You start either an ACE inhibitor or an angiotensin receptor blocker. That's your first choice of antihypertensive. Followed by a calcium channel blocker, followed by a diuretic. And that combination, the A plus C plus D, and then you can throw in beta blockers as and when required. But like Stefan has already mentioned, I will be very careful about using beta blocker in this patient at this age group here. The risk of beta blockers inducing by stroke risk is high with beta blockers, the metabolic risk. Now you could argue this lady is already diabetic, so what are you going to try to prevent? But I would be a bit careful about using beta blockers. But that's not to say that 2023 guidelines have brought beta blockers back into the fold of primary management of hypertension. Okay? So it can be used at any stage in the management of hypertension. Now, if you are not achieving the blood pressure with these 3 or 4 agents, then you can add on spironolactone as your next choice of agents. What should be your target for blood pressure be? Typically between 140/80, if you can get that target, younger patient like this lady who's got diabetes and has got hypertension and probably even some degree of CKD that's setting to go, I would want that blood pressure to be as low as possible. I would actually target in this particular lady a blood pressure of 120 and below, because she's young, she can withstand that low blood pressure, and the benefits that comes with the intensive hypertension control gives this lady protection going forward. So I would like this lady's blood pressure to be as low as possible. Now, one thing that we don't do very well is evaluating response. And I've showed this here in a single slide of evaluating response and how do you go about doing that. In the interest of time, I'll come to the case that we are discussing, and that's about diabetes. So I thought this was a nice way to put it. It says, no diabetes by heart. I thought that's a very cool way the European Society of Cardiology or the American Society of Cardiology put it on there. So your target blood pressure should be 130/80 in a patient with diabetes. And the agents of choice still remains an ACE inhibitor or an ARB. And as needed, you add on a calcium channel blocker. Now the question is, you're all sitting here and saying like, okay, you have different types of renin-angiotensin blockers. Are they all the same? The question always comes. I use a very simple metric. Now, any cardiologist who is here will swear by an ACE inhibitor, right? As a nephrologist, we swear by an angiotensin receptor blocker, because the benefits in the clinical trials have shown that the ACE inhibitors for cardiac protection, ARBs for renal protection. However, we are likely to encounter patients who got side effects to ACE inhibitors, particularly in the Asian population, and that's a dry cough. What if I can give you an ARB which gives an equivalent potential to an ACE inhibitor, but does not have the side effect of cough? And that's what the on-target trial looked at. It looked at telmisartan to be as effective as ramipril in preventing cardiovascular events in patients with high CV risk. It's a unique drug amongst all renin-angiotensin blockers because it's got a long plasma half-life, has very high receptor affinity, and is lipophilic. It provides superior 24-hour blood pressure control, both systolic and diastolic, and it is indicated to provide CV protection for high-risk patients. As a nephrologist, telmisartan gives me the confidence in the management of diabetic nephropathy, as shown in the AMEDEO trial, and also the benefits that are seen in this group of patients are independent of blood pressure control. So a drug that is efficient across the spectrum, starting from endothelial dysfunction right up to end-stage kidney disease. Now, Stefan has already mentioned the importance of combination drugs, and the best combination that's available out there is a renin-angiotensin blocker and a calcium channel blocker, simply because there's increased efficiency and there's a lower incidence of edema when you use compared to CCB monotherapy. And in fact, if you are looking at adding on a second drug, it can provide 5 times greater benefit in reducing blood pressure than by just doubling the dose of the single agent. 5 times, that's pretty remarkable. But it's not just blood pressure alone that is making a difference. It is said that for every 1 cardiac event that you're preventing by doubling the dose of a single agent, 4 events are prevented by using a second agent. So it would make perfect sense to use combination treatment upfront for the management of hypertension, especially in this lady here. Now, this is the lady who's come to you and then she has disappeared and is never going to come back. Are you going to sit and start with 1 drug, small dose, start escalating? No, you can't. You need to start dual pill combination in this patient and bring down the blood pressure as soon as possible. Within 3 months is the expected duration by which we should get this blood pressure down. Compliance always improves when we use combination treatment. Now, my brief is also to discuss about adherence. And I thought this is very pertinent slide because it looks at 3 aspects of it: initiation, implementation, persistence. And it gives you the definition, what needs to be done, and the interventions of being on the medication. Non-adherence definition for implementation is the patient does not take the medications as needed. That's also something that we find in practice quite often. And of course, non-adherence definition for persistence is that patient just discontinues medication, what has happened here. So finally, in glycemic management in CKD, I think it's also very important. It's important because it's very different in the CKD population. When you manage diabetes, things are very different. The hypoglycemia risk is very high in these patients, and there are only very few drugs that you can actually give safely in CKD. And that's shown here. Linagliptin, Tradjenta, as safe across all stages of CKD, a drug that you do not need to change the dose. A single dose, 5 milligrams, is efficient across the stages of CKD. The Carmelina trial is the only DPP-4 showing the CVOT assessment, showing hard kidney outcomes for the Tradjenta. And the efficiency, or the efficacy rather, of linagliptin is consistent across all stages of CKD and right up to end-stage kidney disease, that you should and you can achieve glycemic control. We already spoke about adherence, so we would like to use 2 medications if possible in addition to metformin. Metformin still is the foundational treatment for diabetes. Make no bones about it. We have 2 drugs now here. On one side, you have linagliptin. It has got safety for renal, it's got cardiovascular safety, and it's got the ease of use. And of course, how can a nephrologist leave a stage without talking about empagliflozin? And when you have the 2 drugs sitting in front of you, the renal and the cardiovascular protection, you look at, say, the safety provided by linagliptin and the empagliflozin combination together. And if you put that into the patient, in the end, as the quality of life, what actually matters to the patient? You use a drug which lowers your HbA1c. Excellent. You use a drug that has a 30% reduction in hyperglycemia. Oh, great. And then you have a 3 kg weight loss. Very happy. As opposed to a drug that reduces your HbA1c by 1%, but causes a 30% increase in hypoglycemia, i.e. sulfonylureas, and a 3 kg increase in weight, maybe insulin, as opposed to a drug that has a HbA1c reduction of 1%, has a 30% reduction in hyperglycemia, but then a drug that actually prevents cardiovascular disease and protects the kidney. The benefits are for everyone to see. So thank you, ladies and gentlemen.
Thank you, Professor Bobby CHACKO. Now that we have heard of the presentations and synergized multi-specialty perspectives from our distinguished speakers, let us go back to our patient case. To close the loop, please welcome once again Dr. Maria Rosan Trani.
Indeed, a very productive evening. And so to close, just for the case, as we can see and has been really emphasized by both speakers, at this point in time, as clinicians, we really have to emphasize the importance of lifestyle changes, emphasize the benefits of nutritional and lifestyle counseling. Okay, we may have to serially reassess or reevaluate our patients, although they may start, but as has been clearly pointed out by our nephrologists, we should look deeper into a case like this. And so we have 3 very important messages: intensifying treatment of both your diabetes and hypertension. And of course, we also included addressing the problem on dyslipidemia. And so with that, we close the case. Thank you.
Thank you, Dr. Maria Rosan Trani. Before we proceed with the panel discussion in an open forum, please be reminded of the following. The panel discussion is designed with survey questions. We encourage everyone to actively participate in the polling activity. Kindly log into Slido by typing the event code BICVM, or you may scan the QR code flashed on screen. The QR code has also been provided on each table. Once you are logged into Slido, you may then answer the survey questions. You will be given 15 seconds to answer each question. You may also send in your questions for the open forum, which will take place after the panel discussion. The panel discussion will now begin. Let's welcome back Professor Stefan Jacob, Professor Bobby CHACKO, and Dr. Maria Rosan Trani, with our moderator, Dr. Helen Ong Garcia.
Thank you very much for that. I hope you've been enjoying the lectures. It's about time. Let's hear from you. See, welcome again, everyone across Southeast Asia. And let us now get the polling in place. This is not meant to actually have right or wrong answers, but we just want to know the pulse. How is everyone doing? Are you convinced by the lectures? And please tell us, this is a mission to improve. So just tell us exactly what you think about our question, and please join us. We want your voice too. Let's start with the first polling question then. First question is actually practical. Aside from lifestyle modification, what is your usual initial management strategy in a newly diagnosed, uncomplicated hypertensive patient with a blood pressure of 140/90 millimeters mercury? A, I would observe for 3 months. B, start short-acting RAS inhibitor. C, start on a long-acting RAS inhibitor. D, other monotherapy. E, low-dose combination therapy. Or F, low-dose combination therapy. That is actually, you can read them. I'm a little bit confused with E and F too. I did not type that. Please send in your answers. The answers are in. I'm not so sure whether we're convinced or not, but 68% said they're gonna start on a long-acting RAS inhibitor. And the rest chose the multiple answers. I'd like to ask perhaps our panel, what do you think? Maybe shall I start with the lady first?
Good evening. Thank you, Helen. Yes, this is a very common question that we see in the office. And for me, after lifestyle modification, technically, we are allowed to let them get away with their lifestyle adjustments for at least 3 months. Maybe observe, but as we said, it's an opportunity. So personally, I'd like the most popular answer. I'd go for monotherapy.
I know, Professor CHACKO, one of the most difficult prescription is lifestyle. So do you have any inputs regarding what had happened so far in the polling?
I always have something to say. You know that.
Yeah.
So look, I'm a believer of lifestyle changes, but I believe it has to be concurrently done along with the medications as well. Because it's all about opportunistic management. Because this lady, or any patient for that matter, you ask them to go and lose weight and come back. That's not a very interesting thing for people to do. Lose weight, lifestyle changes, no. You take the chance and you prescribe lifestyle changes, but you also prescribe medications at the same time. That applies for hypertension, that also applies for diabetes as well. We need to move away from stepwise algorithm of lifestyle changes, then followed by medications. It has to occur simultaneously.
Thank you very much. I'd like to add another question. Monotherapy versus single pill combination.
Yes, I was going to say that. So 140/90, a monotherapy is all right. 150/90, I would actually go for dual drug combination on that. It also depends on the age of the patient and what are the profile of the patient and how quickly, because if there is target organ damage already established.
Serious if we say just walk away and do a little bit of diet. If you had a pneumonia and the doctor told you, oh, just go home and do some breathing exercise and come back in 3 months, that wouldn't be a good thing, would it? So I think we really need to explain to the patient that certain things need to be improved in his lifestyle. We should have an assessment as well to really help to coach him, but then also start the medication right away. But I just want to say one word of warning. If we titrate, if you don't titrate, if we go up with the highest dose right away, we might take the risk that the patient will throw the tablets away because he feels dizzy and tired, and he will tell you, I'm not taking that stuff, I can't work. So we need to explain to the patient that it might happen, that with a better control of blood pressure, he might be a little bit dizzy, he should measure glucose, blood pressure if possible. But whenever there is a problem, he should come to us and not stop the drug and then stay away.
Thank you very much. Let's go to the next question then. Since that's the popular answer, let's find out with the next question. In your opinion, which one is most applicable to telmisartan in the management of patients with hypertension? A, it is indicated for the reduction of stroke risk in patients with left ventricular hypertrophy. B, has clinical evidence of improved cardiovascular outcomes in patients with heart failure who cannot tolerate ACE inhibitors. C, is indicated for cardiovascular risk reduction in patients with high cardiovascular risk. And D, has clinical evidence of improved outcomes in patients with type 2 diabetes nephropathy. Please key in your answers now. Thank you very much. As I mentioned, there's no right and wrong answer. I would like to have the disclosure. I did not make the question. I want to get out of this ballroom alive and still married. So let's go through this. Everyone, 59% actually answered letter C, and 20% and actually equal D and E. Now, Professor CHACKO is taking, there are two answers. There are two. Exactly. Maybe we'd like to clarify for our audience, what would actually be our opinion in terms of what is most applicable to telmisartan in contrast to the other sartans then?
Well, I'm glad they listened to my talk, but I'm looking at the questions myself and I'm saying, what would I have answered? B was good, diabetic nephropathy. As a nephrologist, I would have gone to that. And then I spoke about the comparison of ACE inhibitor and an ARB for cough. So B was also a good answer. Maybe C puts it all together. I think that's how they have come to that conclusion. But I could have picked any of that.
Professor Jacob?
Well, actually, I can't not add anything else because I was guessing that C was the first. But also the other D and B are also right, and even A is right, but it's not the indication in the SMPC. But if I have a patient who has left ventricular hypertrophy, I have to control blood pressure, and by that I will improve the stroke outcome.
I think mainly a lot of our audience are actually more familiar and actually impressed by the results of the on-target. Maybe that would explain why majority. Isn't that right, Rosanne?
Yes, I think the on-target trial really showed its benefit, especially in that study. It was a high-risk population, and it was proof that an ARB, telmisartan, could help in that aspect.
I could remember the time when we're trying to actually look for a trial that will actually give the sartans a certain non-inferiority to the ACE inhibitors, and I think on-target was one of the trials that actually did that. Thank you very much. See, we still have one more question, right? One more question or two. For diabetes, oh, I'm sorry. I'm trying to look into, are you still okay with me? I'd like to hear whether everyone's still awake. Are you still awake? Thank you very much for that. And for those who are virtually in your room, I'm sure you're still awake listening to our very exciting questions. You must remember when you're taking your board exam right now. Let's go to the diabetes question. For type 2 diabetes on DPP-4, how often do you check the renal function to determine if patient are still in the appropriate dose? Every 3 months, every 6 months, once a year, or longer than a year? Please key in your answers now. Okay, now we have the answers in. 73%, oh wait, somebody is still changing answers. It's allowed. If you're female, it's most allowed, 90% allowed. If you're male, you're only given 50% allowed to change your mind. So 66% said every 3 months, and 25% says every 6 months. Kind of difficult questions to answer, right, Professor CHACKO?
Look, I don't know who said this question. It's so tough, really, because I got to look at. It depends on the drug that you're talking about, right? You got a DPP-4, you got a DPP-4, you got other DPP-4s. When you're on linagliptin, Tradjenta, your single dose of 5 milligrams is effective across all stages of CKD, and you do not need to check the patient's kidney functions. However, when you are managing a patient with diabetes who has got CKD, you will be monitoring the patient's kidney function depending on the CKD stage. That should remain. But for the purpose of drug, you do not need to check your kidney functions if your drug is linagliptin.
Thank you very much. That's a renal question. So thank you very much, Professor CHACKO. Let's go to the next question. We always respect the nephrologists when it comes to...
I want to say something.
Oh, you have? Oh, I'm sorry.
Because I just, knowing that you all are knowledgeable about it, that linagliptin doesn't require the safety measures, we still, and I just want to reinforce what he did say, we need to check EGFR and UACR every year. Every year, even if this year it was okay, next year we have to check for CKD, but not for the pharmaco safety.
So that's for all type 2 diabetes patients?
Yeah.
Regardless of treatment? Oh, okay. So thank you very much for that. Next question, please. So let's have our next diabetes question. What other outcomes do you monitor in patients on DPP-4 aside from efficacy? A, risk of hypoglycemia. B, risk of cardiovascular complications such as reduced ejection fraction, or I guess 2D echo finding. C, risk of renal deterioration, doubling of the serum creatinine. Or D, frequency from frequent emergency room visits or hospitalization. So please key in your answers. This is a combination of outcomes. I would say some are actually practical, I wouldn't call them outcomes, but more of complications or measures, and some are actually outcomes. So most says risk of renal deterioration, doubling of serum creatinine at 36%, 25% or quarter said risk of hypoglycemia, and the rest seems to look into cardiovascular complications. Letter D is a little bit unusual, but that's 16% said so too. So which would you think, do we need to monitor all of these outcomes, and which would be priority then?
So I'll start. Again, very tough questions. I mean, this is tougher than clinical exams, I can tell you that. Because what are we trying to address here? So again, it depends on which DPP-4 inhibitor that you're going to use. If you're going to use linagliptin, risk of renal deterioration doesn't matter. It matters, but it's not affecting the drug or the pharma management. Cardiovascular complications, we don't have heart failure complications coming with linagliptin. That's not to say that the other gliptins are free of it. Risk of hyperglycemia is very, very low to almost negligible. An emergency room visit or hospitalization can happen with anything. I don't think it's in. So if you're looking for linagliptin, there's probably no answer there. But I'll let Stefan take his view on this.
Well, I would say in any of the patients with diabetes, we should assess all these factors. But it's not necessary if you have picked out the right DPP-4 inhibitors, because I try to explain that number one, the risk for renal adaptation, there is nothing, because you can keep it till the end-stage renal disease. Number two, cardiovascular complications. Sure, we should monitor it, but DPP-4, especially linagliptin, as I showed, has proven clinical safety, even in heart failure patients, and it has proven to have a very low risk of hypoglycemia. And of course, we always need to ask about any hospitalization, yes, but there is nothing which popped up during all these trials in relatively newly diagnosed type 2 diabetes patients and in patients with renal complications. So I think this is a safe drug if you give linagliptin, but as a whole, I would say any patient with type 2 diabetes needs to be monitored for that.
Okay, thank you very much. And I think you actually told it very well. With linagliptin, with the trials showing all of these are actually addressed, it would be fairly safe to say that efficacy, besides efficacy, safety is certain with the DPP-4 such as linagliptin. Let us go to the next question then.
Yeah, I'd like to just again go back. With DPP-4 inhibitors, as was said earlier, the cardiovascular side of things, the cardiovascular outcome trials, specifically for linagliptin, really show its benefit. And if we are to monitor our patients on DPP-4 inhibitors, maybe not so much of those things, but the overall, whether the diabetes is really being intensively managed and things like that, because those are the things that can add to the future comorbidity of the patient.
Thank you. The next question is equally difficult, by the way.
No.
Let's go to the next question. Which characteristic of linagliptin, because we just mentioned a while ago, it was addressed by the trial and it shows it's fairly safe, but which characteristic of linagliptin do you find most advantageous for your patients with type 2 diabetes requiring a DPP-4 inhibitor? Is it in the 2 cardiovascular outcome trials demonstrating cardiovascular safety? Is it the clinical evidence of benefit across a broad range of patients? Is it the clinical evidence on renal safety, no need for dose adjustment, or the quality of the product? Please key in your answers now.
There's no.
The answers show a consensus among all specialty. Of course, it's the clinical evidence of benefit across a broad range of patients at 47%. And the other answers are showing the different prioritization of the specialists that are in the room. So I guess we may ask each of our specialists on the platform today to give their take on which would be your answer. May I start with the lady, please?
For me, there's an impact really on the cardiovascular outcome benefits of linagliptin. And next for me would be the clinical evidence on renal safety. So the clinical evidence across the benefits, yes, it's there, but I'd go for C and A more.
As a cardiologist, I would agree with you. It's very difficult to give a drug that you have concerns whether it's going to cause harm rather than safety. So the cardiovascular outcome trials demonstrating cardiovascular safety has the most impact on me in my choice for any DPP-4.
Well, I think one of the most important things, I have to repeat it again, this is the only DPP-4 inhibitor having 2 trials and having the early stage and the late stage of patients. And I think we have, in the late stage, we have the vulnerable population, but unless you do a proper trial in the primary, in the early stage, in the, let's say, still primary preventive group, you cannot talk about safety unless you have done the study. Because you all know sometimes we have bad surprises, sometimes we have good surprises when you do a proper study, like the heart failure hospitalization with SGLT2 inhibitors would not have been discovered if we had not done the EMPA-REG trial, which as a big surprise did show the increase, the improved outcome, the decrease in the hospitalization risk. Or we were checking the kidneys with the SGLT2 inhibitors like banana because we were afraid it was doing harm, and it turned out that it was protecting the kidney. The same holds true here. What do we do with the newly diagnosed patients in whom we should up-titrate and control as well as possible and as early as possible? So I think it's very, very convincing to have both ends and safety at both ends.
Thank you, Professor CHACKO.
Yeah, I'm a nephrologist, and the one thing that stands out for me is D, that's no need for dose adjustment. So it's open your mouth, one single tablet across the stages of CKD. I don't need to bother the patient's GFR. So that stands out to me from a nephrology perspective. But as everyone said, it's the whole gamut of benefits that comes with it, the safety that comes with it, the weight neutrality that comes with it, the low risk of hypoglycemia. Everything is attractive. But each specialist will pick their own attractiveness depending on the specialty that you come from.
And as a German, I have to say the quality of the product is important too, because it's a German product.
I would agree with you there. Part of my life is quality. Definitely a good quality product is very important. Thank you for that. We're ready with our Slido. I think there are a couple of questions that came in already. Are you ready to listen to the answers for your questions? Let's start the ball rolling. First question, what is the target BP of a young adult hypertensive, and there's qualifier, less than 65 years of age, between 65 and above, and 8 years old?
Yep, easy. So anybody who's older from, up to 69 years of age, your target blood pressure should be, your goal treatment is to get it below 140 over 90 and down. For 80 years and older, it goes up to 160 systole that you actually initiate treatment. So you're relaxing your blood pressure targets when you have an older person. But not every 80-year-old needs to be the same, right? You can have a very fit 80-year-old who can be a nutrition expert, but you need to actually look and say, if somebody is fit, maybe you can reduce your blood pressure even lower in those patients. But by and large, the guideline says 80 years and above, 160, 65 and below, you can start looking at 140 as a systole and 70 to 80 as diastole.
I would like to encourage everyone. Slido is still open for everyone. We still have time to answer your question, to take this opportunity, even virtually or here. I can see that, yes. Keep them coming. We still have time. I will tell you when the time is up. For the next question, let's talk HbA1c. They also went through the ranges of ages. Are there targets in terms of HbA1c, especially for the elderly?
Well, I think in the elderly, we have to see safety first. And we see that the intensification of treatment often includes the addition of insulin. And we have to be careful about hypoglycemia, stumble and fall, and all these things we just discussed, especially in the elderly. So I would also say, in this case, we would individualize. As with blood pressure, we would look at the patient. In Europe, we have a range which goes up to 8, even 8.5 HbA1c in the elderly, depending on the comorbidities, depending on the fitness of the patient, depending on the life expectancy. I tell you, I have patients who have been treated with intensified insulin treatment, 3 times injections of insulin per day with basal insulin, with having had a stroke, being bedridden, and, you know, what is their prognosis? And I think we have no evidence for people above 80 that there is any gain when you control glycemia, and there are patients where you would say no go. But quality of life to the patient is also very important.
Can I also just add on with the question about the HbA1c in a patient with CKD as well? It's not the age that actually dictates the glycemic targets, it's the stage of CKD.
Yep.
Right?
Risk of
So if
hyperglycemia.
you're having CKD4 and CKD5, you can't be looking at a target of 6% HbA1c because the hyperglycemic risk is very high in CKD. So you'll need to relax your HbA1c targets. In fact, there is a U-shaped curve. The tighter the glycemic control in CKD4 and CKD5, the worse the outcomes are. So you need to relax that on that. So age is not a factor there, but the stage of CKD is a factor.
Just one thing I have to add, because I learned it also after medical school. It was a colleague of mine who detected this, that 40 to 60% of the gluconeogenesis is not done in the liver, but in the kidney. And if the kidney fails, the gluconeogenesis also goes down, and that's why the counter-regulation doesn't work.
And as a corollary, as a simple tip, if your patient who's on standard dose of insulin starts getting hypoglycemia, check the kidney functions because the GFR would have dropped, and that's why the patient is hyperglycemic.
Thank you very much. A very fine reminder of the J curve because it is a reality, and therefore we should actually tailor our intensive management for hypertension and diabetes. And then after which, we still have some more questions. Was renin-aldosterone measured in the case presented, considering her age with poorly controlled hypertension? Tricky question for a country like us.
Yes. The case of a young patient, less than 40 years of age, secondary causes of hypertension ought to be looked into and ruled out. So as for this case, no renin-aldosterone test was done. At this point, the potassium, although below 4, but we did not pursue the area of doing a secondary cause of hypertension.
Yeah. And just also add on to that, yes, the answer is that you should be checking because the number of patients with Conn syndrome and hyperaldosteronism is more than what you think is out there in the population. So if you have an opportunity to test for it.
Well,
if you can't test, give the drug.
Can you just tell us which drugs should not be taken when you measure?
Don't go there, Stefan. Don't even go there. There's so much of changes on there, but I wouldn't want to do that now.
Well, in particular, if we're talking about investment of money, I have had so many people coming to me with off-key values, and it turned out that they were measured in the wrong way. So what is the standard to measure it?
So you got to be supine position on there. That's very important. First thing in the morning.
Walk in.
Yeah, there's a lot of factors that comes into play when you're checking that on there. But ideally, if this patient is coming to you for the first time for checking, I would look for renal artery stenosis for fibromuscular dysplasia because the age is in that fitting the group, female, and she's got a potassium of 3.9. I will definitely ask for a renin-aldosterone ratio because Conn syndrome is a possibility, especially with the symptoms of palpitation and what she comes into. Pheochromocytoma is also a possibility. So secondary hypertension looms very strongly in this patient. We just need to keep in mind that it may not necessarily be feasible everywhere to check for it, but you should think of it at least.
Well, one of the issues, that's why it was very important to talk about it. We would probably say, which is the priority test? Because as mentioned, we are off our own pocket, out-of-pocket payment, and the patient would probably not afford the full evaluation for secondary hypertension.
Yeah, so if I can just very quickly, you start the patient on a renin-angiotensin blocker because that's what you'll be doing, and you check the patient's potassium and creatinine 3 weeks later. If the potassium has gone up and the creatinine has gone up, then you are dealing with a renal artery stenosis. That should be the clue for you to go and check for fibromuscular dysplasia. If despite your best medications, your blood pressure is not improving and the potassium remains low, then Conn syndrome is a possibility, and then you should be looking for Conn syndrome.
Thank you for that. Yes,
Thank you.
Roseanne.
Well, the patient came back for evaluation after 2 weeks, actually, from the start. And we just repeated the electrolytes and, of course, the creatinine levels, which were are all normal.
Thank you. Now let's go on. The questions are getting interesting, and I'm looking at the time. I hope we can answer all of them. What are the challenges and strategies in implementing novel kidney protective and cardioprotective therapies in patients with diabetes and kidney disease?
Well, I think, can I take that?
Yeah, you go for it.
If we knew why doctors are not going for it, we could do something. We call it inertia. It has been a couple of years now that we have been running around telling the same stories, but we are not picking it up in a way we should. So we are still siloing, as I said, and I think we really have to get going because we could help our patients. We could reduce, at the end, the costs. We have the evidence that we have great drugs to improve the outcome of our patients. But we have to, number one, detect these patients, then we have to explain it to the patients, and then we have to coach and go along with the patient with the drug management and the lifestyle management in order to make sure that the kidney protective and the cardioprotective drugs are taken.
The guidelines do help. People follow the guidelines, and if the guidelines will actually introduce intensive therapy with introduction of this therapy, I think that would help a lot. Maybe we should affect the people who are doing the guidelines.
I'm a little bit pessimistic. There is one paper in JAMA which was looking at 325,000 people who all had type 2 diabetes, who all had survived a myocardial infarction and a stroke, and who all 100% should be on high-dose statin, RAS blockade, SGLT2 or GLP-1, and less than 5% at all three. And this is in the States.
Very quickly, I think it's a very interesting question, and that also leads up to the second question that comes after that down here. The challenges and strategies. The challenges is, as Stefan mentioned, inertia. We got to wake up from that. We can't be sitting and saying that, oh, you come back after 3 months, I look at your sugars, you got to treat it now. Challenges, also the cost, and that's not to be understated. Cost is a major issue for managing patients with diabetes. So the question after this, if I can read, it says that given that we are in a third world country, do you still prefer to give metformin as the initial drug, or will I give empagliflozin and linagliptin? I have only one answer to that. Metformin, for me as a nephrologist, still is the absolute foundation for diabetes management. There is no drug that surpasses metformin as the initial treatment. The benefit of metformin is purely, mostly at least I should say, for glycemic control. Empagliflozin and linagliptin gives you an added benefit of glycemic control without the side effect profile, and therefore it is safe. Empagliflozin gives you the organ protection that is required. So in an ideal world, I would be giving my patients metformin, empagliflozin, and maybe throw in with some linagliptin to get the glycemic target. I want the HbA1c to come below 6% as soon as possible in my patient, because you're getting the glycemic benefit and the organ protection at the same time.
Shortly, we'll probably say, give the drug that your patient will take, sustained and continuously, and if metformin it is, then that's the one that's going to get the blood sugar down. Last question for the line. What is the target blood pressure with high cardiovascular risk patients? Is it the intensive control to decrease below 120 beneficial for this patient?
I think the SPRINT trial has given us enough evidence that intensive blood pressure control is the way to go. So there's no doubt that you have to, in the high-risk population, drop your blood pressure below 120. But again, you got to determine the patient in front of you. An 80-year-old or a 90-year-old with intensive blood pressure control is not the same as a young person with intensive blood pressure control. The patient matters, and also the CKD level also matters, because intensive blood pressure control in a patient who's got CKD can drop kidney functions by hypoperfusion. So you've got to be a bit careful about how strongly you're going to go for blood pressure reduction there.
Take your time. Don't go too fast to these levels, because I have tons of patients who said they couldn't tolerate the medication. I stopped it, And at the very end, it turned out that they were the blood pressure was dropped too fast. Take your time.
Thank you very much to our dear speakers and panelists. I'll give you 2 titles now for giving us those insight and the very informative lectures. I actually enjoyed them. Allow me now to recap the whole night and give you briefly what had happened. We've heard our speakers and we've heard all of them talk about intensive, aggressive, yet calculated management of hypertension and diabetes alongside early detection and also management of kidney disease. And you know very well that's very important. Never take one body as parts of its organs, but then treat everything simultaneously, and maybe we'll be able to see an older population, an older healthy population in the world, especially in the Asia-Pacific region. Thank you everyone for your questions, and thank you also for the speakers for their insight. Let us leave you with a couple of messages. We came here with a mission, and the mission is to synergize together as one healthcare provider community to enable us to address cardio-renal metabolic care with the way that we were taught tonight and we agreed to tonight based on your answers in the poll. Patients need to receive effective antihypertensive therapy early, and quality of that treatment with its efficacy and safety is important. So we've heard that telmisartan give effective 24-hour BP lowering, is the only ARB with good trials to indicate to reduce cardiovascular morbidity and mortality in high cardiovascular risk patients and also provide renal benefits across the renal continuum. There's actually value in simplicity and a practical management. We've heard the ESC guidelines for hypertension, and also I think it also applies across diabetes, cholesterol, and even kidney disease. A single pill that addresses all, that gives you that calculated range of control will actually lead you there. So when we choose the combination, let's choose the combination that gives the most safety and efficacious way. One of the combination you might actually use, and even across patients with ESRD and even dialysis, is linagliptin. It's the only DPP-4 with established cardiovascular and kidney safety profile demonstrated in cardiovascular outcome programs. Simple 1 dose, once daily, with no problems with kidney affectation, with actually no problems also with cardiovascular complication. With that, I'd like to conclude this symposium. I hope everyone enjoyed, whether you're here in the room with us or out there listening as we conclude this Congress tonight in its year-long saga. In Tagalog, I'll say, maraming salamat po. I don't like to say it in German because I don't know how to say thank you in German.
Danke.
Thank you very much. And then to everyone across here, maraming salamat and thank you for attending this Congress, and thank you to our speakers.
Thank you to all our attendees on site and online. We appreciate your questions. All participants are requested to complete and submit the evaluation form, which you can access through the QR code flashed on screens, or you may go to Slido and use the same event code BICVM to access the survey form. Thank you, Dr. Helen Ong Garcia, Professor Stefan Jacob, Professor Bobby Chacko, and Dr. Maria Rosan Trani. Thank you for participating in the CVM Congress, Breaking Barriers, Unveiling the Future. Beringer Ingelheim Philippines looks forward to strengthening collaborative care with all of you in the management of cardio-renal metabolic diseases. Please enjoy the rest of the evening.
Recording stopped.